Hello, and welcome to December 2020 CME session of the Virtual Journal Club. Before we get to today's topic, allow me just to reflect briefly on the sessions we have covered this year. So, an unusual year for sure, a strange and hopefully never to be repeated year for sure. We started it thinking in a way that I think prepared us for what was coming. So in January, we talked about massive open online courses, or MOOCs, and the promise as well as disruptive nature that it had for our field. And then we talked about the vision for 2020 in February, just before the annual meeting, and we had our colleagues, Dr. Dave Davis and Ms. Ginny Jacobs, walk us through that kind of vision of thinking through how we could be more attractive with our programming, more efficient and effective and patient-centered. And then COVID hit. And so already in March, we were responding with our community's response for global pandemic. And it was the time of quick switches and pivots. We followed in April talking about what the future of online education could look like by reimagining medical meetings from live to online. And then over the next couple of sessions, we really refocused and started thinking about post-pandemic time. And so how do we do online education more effectively? How do we use good design and not just a quick pivot to address our educational needs with online education? And then we talked about, with a group of colleagues from Toronto, University of Toronto, about assessing outcomes in program evaluation of online learning. And that was a very well-received session. So I invite you all to go back when you have time, maybe over the holidays, and look at these sessions, revisit, and see if there's something that you can learn from or take to your programming. And then finally, in September, we looked at a topic that, again, could be very timely and interesting for what's facing us in terms of content. We talked with the University of Boston University colleagues about the effect of mandatory education on CME outcomes. And this was based on their extensive work and research into safer opioid prescribing education. So today, we, in a way, are providing a retrospective on the year, this interesting, fascinating, yes, we all know, very difficult year, but also the year that I think all of us will agree provided an opportunity to think differently, to maybe advance, to retool some of the things in our programs and in our thinking. And I am really delighted to be able to bring back a group of colleagues and friends that originally got together this summer in preparation for a session we delivered at Stanford's CME Live. And all of this was really sparked by a terrific article that Dr. Craig Campbell and Dr. David Price contributed earlier this year as their reflection of what should we be thinking about moving forward, that was sparked by this pandemic. So without further ado, I'd like to introduce our panelists first. So Kristen, thank you very much for this session that we have titled Considering the Future of CME CPD Post-Pandemic, Never Let a Good Crisis Go to Waste. The idea here is that each of the segments that you will see discussed will be led by introductory remarks from one of our panelists, but we would like to engage all of you in the discussion and understand better where the needs are moving forward, as well as the solutions. So one way we talked about is we provided a survey that some of you were very thoughtful in providing your answers to, and then we'd like to hear more from all of you during the discussion time, and I promise you we left enough time for that. So we have Dr. David Price, with us, who is the professor of family medicine at the University of Colorado School of Medicine. He's a senior advisor to the president of the American Board of Family Medicine, also associates at the Wentz Miller Global Services, and health professions education, continuing professional development, and QI advisor and coach. Welcome, David. We have Dr. Kathy Chappell with us. She is the Senior Vice President for Accreditation, Certification, Measurement, and the Institute for Credentialing, Research, and Quality Management of the American Nurses Credentialing Center. Welcome, Kathy. From Canada, we have Dr. Craig Campbell, who's the Director of the Curriculum at undergraduate program at the Faculty of Medicine, University of Ottawa. He is also a practicing clinician and a member of Division of General Internal Medicine at the Department of Medicine at the University of Ottawa. Welcome, Craig. And then we have from Lisbon joining us, Dr. Helena Philippe from the Department of Medical Education at the Faculty of Medicine. She's a consultant of ophthalmology at the University of Lisbon. Welcome, Helena. And Dr. Todd Dorman, the Senior Associate Dean for Education Coordination, Associate Dean Continuing Medical Education, Professor and Vice Chair for Critical Care at the Department of Anesthesiology and Critical Care Medicine at the University of Johns Hopkins School of Medicine. And for those of you who don't know me, I am Ila Kostic, and I am the Strategic Advisor at the Stanford Center for Continuing Medical Education at Stanford Medicine, and have been running and imagining this journal club, and I will be your facilitator today. So thank you very much. We can move on, Kristen, so sorry. And these are the topics that we have outlined and the presenters. So I think we can get started with David's presentation. Thank you.
Good morning, everybody, or good early afternoon for those of you on the East Coast. Thanks for joining us today. And for those on the East Coast of the United States, I hope you're enjoying what we get to enjoy in Colorado and what Craig gets to enjoy in Ottawa during these winter months. Next slide, please. So we all know that we had a very interesting series of events happen early in the year. And when the pandemic hit, it seemed like the great majority of us appropriately went into survival mode, or the lower rungs on Maslow's hierarchy, when it came to the initiatives and workings that we do in CME. So the discussions, as I observed them, seem to be around how do we take our current CME and move it online? Now that we have this kind of program that's not really been envisioned to any great degree, what do we call it for purposes of accreditation? And what's the business model for our sustainability in the near future? Next slide. So Craig and I, in one of our periodic cross-border Zoom summits, were talking about our various experiences, and it occurred to us that in the midst of this crisis, there might be some opportunities. So the picture you see on the right hand of your slide, of course, is Winston Churchill, who, among many things, is famous for saying, "Never let a good crisis go to waste." So that became the inspiration for the thought piece that Craig and I wrote that was published in JSEP that you see on the left side of your screen. Next slide. So on the left of the slide, we outlined these 5 areas that we thought might be opportunities for us as a profession over the next several months and beyond. Retooling in response to healthcare and public health needs and system needs. Craig and I had initially thought that more in terms of clinician retooling, which relates to competencies, and Todd also ran with this a little bit, and as he will talk about, the implications also for retooling the CPD office. Craig is going to talk about new competencies, and we also thought about ways of reimagining how we use technology and teams in our CPD work. And then, of course, this has implications for patient-centeredness, which I will briefly touch upon. On the right-hand side of your slide, we also envision that there are opportunities really for us to do two things. We all know about the flipped classroom approach to take advantage of people's in-person, if you will, exchanges and how we might maximize that. And more importantly, most of us know the literature about what makes effective CPD as relates to translating learning into practice, longitudinal and multimodal and so forth and so on. And we probably don't do enough of that. And our hand is going to be a little bit forced now and has been a little bit forced by nature of this pandemic. So there are opportunities to create really more longitudinal, multimodal, spiral curriculum type of educational interventions going forward. Next slide, please. So from the patient perspective, the graphic on the lower left of your screen is a graphic to indicate patient-centeredness. And whether or not we are physicians or nurses or other healthcare providers, we all know that we are being appropriately expected to be more patient-centered. But rather than being patient-centered from the rather paternalistic or parental approach of we know what's best from the patient, it really is about us listening to the patients from their perspective. And as the graphic in the middle of the slide shows, there are numerous surveys that are being used, and the links on the bottom of the slide show some of those surveys that attempt to get at patient perception of their involvement and their satisfaction, if you will, and also their suggestions for improvement with how healthcare is delivered. Next slide. So what we have gone to is the old days, or the not so long ago, but now old days on the left-hand side of this slide, where our interactions with patients were mostly in person. Sure, we had some letters and we had some emails and some phone calls, but by and large, the bulk of patient care was delivered in person. And now we find ourselves in the situation where for at least the early to middle months of the pandemic, we are in the world of virtual care, not quite to the realm of the Jetsons yet for those who are old enough to understand that cultural reference. But most of the care has been virtual. And now we are in the mode, most of us, where we're doing a little bit of hybrid, some in person and some virtual. And really, the expectation is that this is going to continue for the foreseeable future. So this gives us the opportunity to think about how can we really take the patient perspective into account when we're delivering both virtual and hybrid care. And before I turn it over to Kathy, I'll just point out, Mila mentioned the survey that many of you took the time to answer, and many of you provided some good thoughts about how we take into account patient-centeredness in this new world. So, for example, technology access. Many patients don't have access to technology. For many of us, learning the tech and all of its foibles and learning what to do when it works and doesn't work is something we're going to have to figure out. How do we create connections and show empathy with patients in virtual formats? We have the advantage by using video, at least we have body language and verbal cues, but it's still important for us to learn ways, and these are teachable skills, to create empathy. How do we build trust with patients when, even though 80 to 85% of the diagnosis might be by the history, there are times when touching the patient is important, either for the exam or to create that connection. So how do we build that trust when we literally cannot reach out and touch somebody? And there are other really good ideas that were raised in the survey, and I hope that we can either talk about them later today or in ongoing efforts over time. So thank you very much, and I'll turn it over to Kathy, I think. Next slide.
Thank you. Thanks. And I'm going to pick up on a couple of the things that David talked about. I think in particular that virtual environment, not only how are we caring for patients, but how are we working collaboratively as a team when we're all in different places also. And yes, I'm old enough to have remembered the Jetsons and watched the Jetsons at the time. So if you go to the next slide, thanks. So based on the article that David and Craig published, my focus is really going to be on interprofessional continuing education and how that can be a strategy to foster team collaboration. And really more specifically in relation to the pandemic, what's been the impact of COVID on interprofessional continuing education and how teams collaborate. So next slide. Great. So I am a glass half full kind of person. I think we should lead with our strengths. And I do think that we have a lot of work that we've done that we can leverage in relation to interprofessional education and expectations for healthcare teams. So for example, in the top left, ACCME, ANCC, and ACPE created the Joint Accreditation Program, and that incentivizes organizations to invest in interprofessional continuing education as a strategy to improve interprofessional collaboration in the practice setting. We accredited our first organizations in 2010. We have over 100 organizations that have achieved joint accreditation and all different types of organizations. And for organizations to be eligible for this program, they have to be doing 25% of their education by the team for the team. What we found over the past, moving into 11 years now, is when organizations invest in interprofessional continuing education, accreditation is a strategy to incentivize organizations, but they really dramatically increase the amount of team-based education they're doing as they realize it's a value proposition for the team. And also it has a positive impact on patient outcomes. Right now, organizations that are jointly accredited can give medicine, nursing, and pharmacy credit, but we've also added 6 other accreditors that are depicted on the slide here. In addition, the National Academies of Medicine have invested in and published a significant number of resources for team-based education, and almost everything is free. JSEP continues to publish articles related to interprofessional continuing education, and there are multiple competency frameworks that have an expectation of interprofessional collaboration and communication embedded into them. And that is in medicine and across the healthcare professions. Every single accreditor at this point has the expectation that people are learning together in teams. Next slide. So what are our challenges? Well, in interprofessional education or in continuing education, we continue to battle a history of professions that have been educated in silos and to some extent have practiced in silos, so I think that is breaking down. But that history of education has been a barrier to team-based care. I'm hoping that we are continuing to make progress in that, and I certainly have seen it from my side. But when COVID hit, we had to pivot our education and practice systems very rapidly. And I equate that to changing the tires on a car that's driving at the same time. And we've had to respond to evidence that was relatively sparse at first and then began to change rapidly. And we had to start to make significant changes, or they had a significant impact on our revenue streams, regardless of what type of organization. If you're in the practice setting, certainly it's impacted you. And if you're primarily in the education setting, it certainly impacted you also. Next slide. So here are some areas that I outlined in relation to the impact of COVID on our current system. Certainly, we had to very abruptly move to digital and online education and eliminated those in-person conferences and meetings. That meant we had to access new resources, we had to use new platforms, and we had to upskill our faculty in order to be able to deliver content in a way that they hadn't needed to in the past. We had to increase just-in-time education, both at the organization and at the unit level, and deliver more resources to those at the point of care very quickly. We've had to manage multiple and competing resources. Again, we've had a significant, some have had a significant decrease in revenue, sometimes resulting in layoffs or furloughs. But we've also had the opportunity to engage more stakeholders in digital and online education. So because we're less dependent on travel and it's less expensive, we've been able to sometimes expand our networks across professions and really geographically, as represented by Helena today. So next slide. So how does that impact interprofessional continuing education? Well, I think I've seen a lot of increased engagement across professions that maybe hadn't existed before. Our healthcare teams continue to be under significant stress, not only in terms of their own personal health and safety, but that of their families. And we've seen an increase in burnout across all the professions. We have seen healthcare teams and organizations, I think, really lean into this pandemic and work to achieve a common mission. I'm an ER nurse by background. I think, you know, you see a lot of teams forming together and responding to mass casualties. There is a thread of that ran through particularly early. I think what we're seeing now is some continued fatigue as we ramp up and ramp down, and there's only so long that healthcare teams can manage to do that. We have challenges related to more silos in practice in relation to isolation for healthcare providers because of COVID patients and decreasing the opportunity to co-locate teams in physical spaces. And I think we have the opportunity to demonstrate the value of interprofessional continuing education and meeting goals at multiple levels. So at the department, at the organization, or our own personal goals. And next slide, and that's my last one, I think, before turning it over. So what does the future of interprofessional continuing education look like? Well, I would argue that team-based education and team collaboration are critical to achieving any organization's strategic goals. We're going to have to continue to work to decrease silos. We're going to have to focus on team-based education and meeting the needs at the point of care and deliver team-based education across multiple platforms and to multiple audiences. Anything we do is going to have to be cost effective and outcomes driven. And we need to continue to invest in faculty development as they move from a uniprofessional model to an interprofessional model. And I'm looking forward to feedback from you all after our presentation. And I think at this point, I am turning this over to Craig, if I'm not mistaken. Thanks. Craig, you're muted.
Good afternoon, everyone. I'll try again. So Kathy referenced the rapidity of the change that we all experience, and it happened at the individual level of a health professional's practice. It happened, you know, for organizations who deliver and support health profession education, and it certainly happened at the healthcare institutions, along with the regulatory bodies that govern the practice of the health professions. It was just an interesting opportunity for us, as Dave and I were reflecting on the idea that a competency lens may be very important in the way we think about the rapidity of the change that is required. And I'm going to talk to you a little bit about that. Next slide. So you might ask, well, why would a focus on competencies be even thoughtful at this point? And because the natural tendency would be to think about, well, just what, you know, medical knowledge would we require or skills to essentially deliver care in a different way. But a focus on the broader competency frameworks would help us focus on the learning and continuous improvement that we need, you know, within domains that certainly matter to patients. They certainly want us to be much more communicative, collaborative with other health professions as part of that team-based focus, you know, areas of professionalism and leadership. But it also helps us to integrate the educational process and the change that we all had to pivot to make, you know, within the healthcare delivery systems that we're focused on trying to address the pandemic's impact on specific communities and populations. And it would help us at an individual level for those of us who are called to start to perform professional roles that we may have performed in the past, but not in the recent past, to be able to think about what do we need to do to educate ourselves to contribute to the impact that the pandemic has had at multiple levels in terms of our own competence, and to be able to perform well within this rapidly changing scope of practice. Next. So the idea of a focus on competencies might be important, not just within the pandemic itself, but subsequent to the pandemic for a couple of reasons, because competency frameworks are one way to think about thinking about the work of the profession, the things that we perform on a day-by-day basis, is to think about, well, what is the knowledge, skills, behaviors, and attitudes that all health professionals require to actually perform that work? And if that work is rapidly changing, a competency framework allows us to link that knowledge and skills and abilities to the actual work that we do. And the other is that it helps us to think about competencies as a lens to think about the kinds of goals that we're trying to improve within our own professional practices, to create a practice-specific CPD plan that enables us either individually or collectively to ask, well, what do we need to learn to respond to the health needs that are rapidly evolving in front of us? Or where can my individual or our collective practices improve? Next. So in our own experience here and in brainstorming with colleagues, some of the examples of new learning domains are kind of articulated here. So Kathy mentioned that, yeah, we had to start delivering care and delivering education and continuing education through these virtual platforms. But what are the skills and competencies we need to do that well? How do you actually perform a virtual patient assessment? Is there aspects of a physical exam that you can actually do through video conferencing? And for those of you in my setting, I supervise students and residents who are also trying to figure out how to use telehealth or telemedicine networks. How do we supervise them in ways that will enable their own learning and provide an appropriate supervision strategy for them? For those of us who had to go back into the hospital environment and deal with either COVID positive patients or those who may be suspected as being COVID positive, or at least we're concerned about that. I mean, the whole strategies of figuring out what personal protective equipment we need and the skills of actually putting it on and taking it off in an effective way to protect our own health and well-being. And then how do we actually communicate effectively, not only with individual patients, but their families when there was such restrictions to their access to the healthcare system. So in our setting, we started using phones and tablets and even email as a communication strategy, which we never used before. Next. And this was also an opportunity to learn new content domains, so obviously, what COVID-19 is and all of its manifestations. But, for me and for many of us, I think it was around learning a lot more than I ever thought about what public health and its processes and practices mean, for me and my family, and also us and our care of patients. We've been guided by public health, both processes and recommendations in informing all of the things that we've done, both at an educational and a clinical level. It helped us to think about some of the broader ethical principles for how do we allocate health resources when our health systems are starting to become overwhelmed, at least in early stages of this. This happened both within North America and within Europe in general. And how do we do all of this and support wellness within our workplaces? Where we went into this pandemic with concerns about the profession's wellness and the rates of burnout, and this simply added significantly more to the stresses across the health professions within the workplace itself. So learning more about these areas in a competency lens gives us that opportunity to give us permission to do so. Last slide. Next one. And the other was about relearning things that we might have learned in the past that are part of our discipline, the things that we were trained to be able to do, but haven't done for a long time, like procedures. In my world, it would be putting in a central line into a patient, which I haven't done in quite some time. So if I have to go back into a workplace and be able to be expected to perform that, I'll need to upskill and train in a modern way about how to perform that procedure today. New diagnostics or therapeutics within a new evolving context that we may not have been seeing patients with that kind of disorders or presentations. And then the whole practice management competency sets around providing effective handover for those who move from more of a solo practice into a more hospital setting. So lots of opportunities to relearn past learning as a new set of competencies that were relevant, I think, across all health professions. Next. So those were those were some of the skill sets, and the ability to deliver it was more through a technology platform. And Helena's going to talk to us more about that. Helena.
Thank you so much, Craig. And greetings from Lisbon, and a warm embrace, virtual embrace to everyone who's present. My admiration to Mila for her leadership at the helm of the virtual journal club of the SACME, and a word of acknowledgement, of course, for being part of this one. We aim at opening with this intervention, opening a door for a conversation around how technology can support medical education in terms of the pandemic and also after the pandemic as well. Next slide, please. And this will be anchored on the reflection of Dr. Campbell and Dr. Price, whose article has been presented earlier and is here also cited. And we could have this critical questions within technology, which is how can technology ignite learning, supplement and reinforce in-person learning environments, promote communities of practice, and support partnership and support CPD, faculty development, and also partnerships within these leaders, and also include QI and etc., etc. And we will situate these questions, this reflection embodied these 4 questions within CPD and faculty development by having some 3 examples to illustrate our line of thought for you to ignite this this conversation on technology. Please, the next slide. So before going any further, I would like to emphasize this message that is, technology is not here or came to replace the educator, but if the educator has skills and expertise in technology, probably he will be much better equipped for teaching and facilitate learning than those who don't have those kind of skills. And also emphasize, and in this same line of thought, that learning outcomes are not the sole influence of technology. They are the joint influence of a combination of factors as design, implementation, the context, the characteristics of the community of learning together, the educators, the learners, interacting among themselves with the materials, the didactics, their motivation, and the technology. So the outcomes are not from technology alone. This is to emphasize that the human factor is more than important in education. The next slide, please. So for illustrating the possibilities that technology might be as an ally, partnering with the educators, the providers, the planners in medical education, and I would say in education in general, for the first 2 questions, to ignite learning and to supplement and reinforce in-person learning environments, I would like to highlight the model proposed by Margolis and Associates, which is the extended congress that leverages time extension, space, and languages. And by this, we mean that there are opportunities to anticipate and to extend learning, the learning process and engagement of the learners and interaction of the learning community before and after the critical, the main synchronous moment, either it be online or in person. And what is also very interesting is that learning afterwards can be embedded into the practice setting and be so extending exactly the moment of interacting with content with the community of learning that assembled together for a specific learning experience. And this can be provided and held with several languages and also in several settings at the same time. So it's the span is so much big that the outreach is as well very much higher than not having the opportunity to have access to technology, and again emphasizing the important role of the educator and the planner to devise all this structure and content and all this learning format to be in place. The next slide, please. And the next example as technology can promote and support communities of practice is this as Mentors Across Borders. Mentors Across Borders is a community of diverse, dynamic leaders in healthcare profession education. Some of them had met before, earlier, co-working together in a face-to-face speed mentoring workshop at the CME conference, but a whole more educators could join by the help of technology exactly during the pandemic, and the technology could support exactly as a platform for this community to strengthen their bonds, to achieve results, as we can see in the slides. So thus far, 4 publications have been accomplished, 5 Zoom workshops in the format of World Cafes, and providing this aim of the community to promote collegial global conversations about important educational topics in a safe, trustful space to interact, in this case a virtual space, and share in this space successes, surprises, stories, challenges, and potentially enhance professional identity. This is very exciting because it's safe and we can grow together using technology, no matter the time, the place in the world, and also the virus, the pandemic. The next slide, please. And the last example that I would like to show and to share with you is this faculty development program, online faculty development program that was designed and implemented mainly at the start to outreach for our colleagues of ophthalmology of the Congolese Society of Ophthalmology, and later for the Mozambican College of Ophthalmology. And this later one was held during the peak of the pandemic. This is an online program running in the platform of CyberSite, and this is also an example of partnership that technology makes possible between, in this case, Orbis, CyberSite, and the International Council of Ophthalmology. And the program is a collection of flipped classroom 11 modules that were structured as with a pre and a post quiz, a pre-recorded brief didactic lesson, some curated readings, an activity, and all those modules culminating with a synchronous moment where everyone in the community could share experiences, doubts, concerns about the topic, and also about their professional lives and personal lives, because it was possible to create this bond between all the elements present and feel as a real community of learning. A word of remark for the community of practice based in WhatsApp that we could create, and was a rewarding and exciting surprise as it was so easily used to share resources, share experiences, make announcements, practical information about the courses. And it was also a way of the members being together and being more engaged in learning and calling each other's attention that we will be having our synchronous moment, the time of it. And it was very, very rewarding and very, very interesting to create this kind of program. I would like to say that this program is is a tutor assisted model mode. But we have also a self-paced mode running in the CyberSite platform, which for me is very interesting, but not as much as exciting as having this community and feel all the members together, evolving together and growing together. And this is really possible using technology. So most of this, the synchronous moments, we used Zoom. For instance, for the Congolese society, we had to at the beginning using very simple tools because we didn't have the partnership already established with CyberSite. So we advanced anyway with email, with the WhatsApp, with the Google Forms, etc. We would like, our aim was to evolve and grow together. So these are the 3 examples that I would like to share with you. I expect that and would like, hope that these examples and this reflection proposed by Drs. Campbell and Price will open an interesting and exciting door for a conversation afterwards. So thank you so very much and be safe. Thank you. The next slide will be just the end, and I will pass the word to Todd, please. Thank you.
Thank you, Elena. So my part, which is technically not in the article by David and Craig, but we thought was an important way to sort of think about other thoughts at the organizational level, as well as reiterating and maybe repackaging some of the thoughts that you've already heard. So next slide, please. I wanted to start by making the point that a lot of people see COVID as the disruptor, and I would suggest to you it's not the disruptor, that the disruption in medical education was already occurring, and we were resisting a lot of the technological interventions. That COVID has been an accelerator of that disruption and forced us to pay attention to it. Next slide. For some of us, you may feel at times as though, as you're thinking organizationally, as though you have a target on your back. And next slide. And I want to remind you that it is possible that some institutions and some organizations' response to what has occurred would be, why CME? Why continue doing CME? Why not let people just get CME on their own, or et cetera? And so I just want to remind you that if this happens to you and you do feel like you have a target, then think about focusing at the value of CME and CPD. Remember that it's vital to all of the players, including the organizations. It can be a strategic lever if it's done correctly, and there are numerous previous presentations and a chapter in the CPD book as well. But even if all of that is true and it's a value and it's always been a value and it's been doing a great job, should it just stay that, or is there a better mousetrap? And next slide, please. So the first thing I want to point out is while COVID is on sort of clouding the airways and cramming and ubiquitous in our environment, one of the things and roles that CME can do is try to allow people to learn about COVID, at the same time reminding them that COVID is a bit of a distraction to all the other diseases that are still occurring. And that we still need to provide education on. So it's important to remember our global role in education and not get lost in just the moment. Next slide, please. One of those things that have come out of COVID that, again, existed before but was not paid as close attention, but the pandemic really has solidified, is this idea that medicine and public health are intimately intertwined, and not different schools and different universities, but actually hand in hand connected. And this may be an opportunity for you to think about how you reorganize around providing medical and public health education. Next slide. So the approach I would suggest you take, and if you could just go ahead and click the build, is to envision what the world of CME, CPD would look like. Keep going, just go ahead and build the slide. Envision office designs that support that vision, then think about staffing models, and then once you've done that, you can get to the last bulleted item, which is business plans and timelines. So, Kristen, next slide, please. So, I would encourage you to think about breaking down what's happening to us and what you think you have to build going forward into at least 2 parcels. One is the sort of intermediate or short, medium term, which I'm going to call the next 2 years, and then what are the 5 years after that? It's hard enough planning that much of time, but clearly there's going to be a continued move to online, both synchronous and asynchronous. I think we would, 100% of us would agree to that. You're going to have to think about what your role is and what type of CME organization you are, what will happen to live meetings, and will they exist for you at all or not? You know, professional societies clearly will continue to have some live meetings. There'll be some regional meetings. How far will that extend up and down the spectrum of what's going to occur? And what are your models for staffing relative to this? And what are the skill sets that are going to be needed in your staff in order to support maybe not how to find a hotel and how to book banquet services, but how to use technology, how to intro speakers, how to change slides, a host of other technologically oriented skills. And the subsequent 5 years are some of the same questions, but also start to bring in what do registrants want. Right now, they're willing to accept almost anything because they understand the environment. But what will they expect out of workshops and networking? Do they want to do those live, or are they willing to see those technologically enabled and find that those can be done as well? Please, next slide. So one of the other areas you might think about if you haven't really dove heavily into, and to echo what Kathy was talking about earlier, now may be the time for interprofessional continuing education if you haven't joined hands in the circle quite yet. And next slide, please. So what we've done through those slides very briefly is to think about how you might envision what the world is going to look like, and then office design around it. And I'm just going to share with you maybe 2 slides around that, 2 or 3 slides around that topic. And next, please. This first piece is, again, to try to reiterate the retooling piece that David mentioned early on, and thinking about what the skills are going to be needed from the 30,000-foot view. So if live meetings are going to be less and everything is going to be more digitally dependent education, no matter what the tool sets, Zoom, Panopto, et cetera, what are you going to do? How are you going to learn those? How are you going to integrate those? How are you going to have people be comfortable with those? And who's going to be providing that for you? Is that going to be new skills built into your office, or are you going to partner with others as part of your organization? Accreditation is going to remain critical. I think there'll be a growth of focus on things like maintenance of certification or competency, joint commission, and integrating that with CME and IPCE that we've already stressed. And then there's the actual retooling. Who's helping your physicians and nurses and teams retool? And then who's helping your staff think about retool? And how are you doing that with formal assessment and evaluation? And next slide, please. So what's on the horizon? And go ahead, quick, Kristen. So when we did this work in our shop, we discovered that there was all sorts of offices. Office of Audio Visuals, the Simulation Center, Faculty Development, Academic Computing, Assessment and Evaluation, all great, and they all have to overlap at some time in order to work together periodically, but not necessarily in a well thought out, strategic plan, coordinated way. Next slide. And so the work we're doing now is to try to figure out what our bubble cloud should look like. Should all of those exist? Should some of those be subsumed by others? Should they overlap? If they overlap, how much do they overlap? How do you formalize that so it's not one-off overlaps where things can drop and people can forget to get certain tasks done because they're not used to working together? How do you standardize all of that? Again, all with the desire to create a model that's going to help us continue to deliver value and to increase the value of what we deliver, because it's all about the patient and the family, right? And to get the patient and the family the best care, we want the clinical environment to provide the best care, and to do that, we need the best delivery model for how we do that. And next slide. So Mila, I'm going to turn it back over to you now, and you're going to cover some of this and then open the door for Q&A, I believe.
Thank you so much, Todd, and thank you all of you for terrific introductory presentation. So it's now time for you, for everyone to get involved and engaged. I thank many of you for providing written questions already, and I just wonder if there is anyone who would like to contribute a commentary, either a question or something from your practice and solution. So the way to do that is you would raise your hand, and then I can unmute your mic. In your dashboard, you'll see a hand icon. If you click on it, here we go. So we have Franz, I will unmute you. Would you be able to talk, Franz? Saint-Germain? Don't know if this was intended. Okay, let's go to Gary Feldman.
Can you hear me?
Yes, we could hear you.
Well, thank you all for an interesting academic set of presentations from inside the academic bubble. I tuned into this session because I was hoping that you would answer specifically the following questions. What is the evidence that frontline providers, I'm talking about in 4,000 community hospitals, 1,300 community health centers, medical groups, and so on, are looking to or relying upon CME to enhance their competencies to cope with the epidemic? What is the evidence? And if they are, what CME meets their needs as defined by them, not by CME providers? If you can answer those two questions, then I think we will have identified what is the opportunity and the challenge that the COVID epidemic represents and presents to CME. That's what I want to hear, and I think that's what they need to hear. The rest of this stuff is academic bubble talk.
Thank you, Gary, for your commentary and for a provocative question. I think partially we really focused on that during the presentations, and I'd like to just hear from our panelists. Anybody who'd like to start addressing this? Go ahead, Craig.
So I'll start. I mean, I can only deal with our local environment. So, you know, our CPD office, our faculty development office, was very involved in providing the need-specific issues that people were asking for in terms of the transition of care. Some of us didn't have to transition very much. You know, we were still treating patients in, you know, using it in a different way, but in the same, you know, in the same practice setting. But many had to, you know, went to a COVID center to do COVID assessments of the public as they were coming in, and there was targeted education related to, you know, PPE and the issues that they need to do, the assessment of what we knew about COVID at the time. So, you know, we were trying to respond at the local environment to you know, to the specific needs that people were asking for education regarding. And that was very interprofessional. So it wasn't just docs, it was the nurses and mainly in our setting, nurses and physicians, but not, you know, with that in the COVID centers, it would be one example. So a lot of people were asking questions and wanting webinars around the specific issues that they were asking for about COVID and who to assess, and, you know, what about, you know, but the public health, how do you apply those public health directives? So there was lots of those targeted webinars. So I thought it was a good example of what you were talking about.
Yeah,
no,
go ahead.
I was going to say, in our experience, Dave, to try to answer in part, people spoke with their feet, so to speak. In other words, the more COVID education that we could put out, whether it be in our local environment, regionally or beyond, the more people were signing up to take, and the more we were getting requests for additional education. And that was not only of just the frontline providers directly, but as Craig has said, there were a large percentage of people who were pulled into the environment and had to be retooled. You didn't have enough respiratory therapists to cover all the ventilators that existed in the hospital, so we had to find other providers, plastic surgeons that were now working as intensivists, but in tiered models of care, and that they had never experienced before, and they were sort of being a super fellow, so to speak, but trying to do that in a field that they didn't have. And so there was their everyday education, and especially during the first wave, when there was a sort of new knowledge entering the space almost every day, we went to a short journal club almost every single day in order for people to be able to stay up on what was the latest information, whether that be prior to remdesivir and steroids, or even as those were emerging as potentially some of the first thoughts of education. So, and we were having to do that with almost all technology because we were told, you know, hands, face, and space. So,
Yeah, and I agree. I agree with both of you. I think what we've seen at Stanford also is hundreds of programming that is emerging daily on the COVID topics as the needs are emerging, and so as these requests and needs are coming directly from the community of clinicians on the ground.
Sorry.
Go ahead, Kathy. Go
I
ahead.
was just going to say, I think there's absolutely the kind of clinical care and the retooling and reskilling. I would say we've also, nursing has also spent a tremendous amount of time supporting the health and well-being of nurses who are, sitting with patients by themselves while they're dying, and how stressful. It is stressful on the entire healthcare team, but that has been a theme that has continued to stay front and center. And what kind of advocacy work and are you doing to support your healthcare workers?
I would like to underscore that idea, and also bring forward the well-being as a topic, as Craig pointed out in the presentation. And that was exactly one of the topics that were brought about in the World Cafe, the Zoom workshops that we have held in the borders across, in the mentors across borders. So it became so much important. Burnout, well-being, how to cope with this, how to educate in a chaotic zone, how to adaptive our leadership as educators, as professionals. That was exactly those were the topics of our workshops. I don't know if this.
Thank you, David. Would you like to add anything?
I think in the interest of time, seeing other questions, I don't think I have substantive stuff to add at this point.
Okay, thanks. So let's go back to the written questions. There were many, quite a few related to the team-based care and evidence that it really makes a change, makes a difference in terms of patient outcomes. Thank you, Dr. Simon Keto, for already providing a great reference, and there are many more. If you look at Joint Accreditation, for example, or Nexus Group from Minnesota, there are a number of resources available to you. So we won't spend more time on that. I'd like to also maybe address the question from Dr. Tom Van Hoof, who provided both a question and a commentary. He said that it was, in a way, it feels like we are chasing different technologies, and it should be about education. We all agree, certainly, about that. And finally, the question is, will we ever be able to focus efforts on making our education more effective if we are forever chasing technology? Thoughtful question. Anybody? Go ahead, David.
Yeah, here I'll chime in a little bit, and I'll harken back to my days in Kaiser when we went from no electronic health record to a homegrown IBM product to an Epic product. And one of the sort of little catchphrases that came out is OO plus NT equals COO. Old organization plus new technology equals costly old organization. The point being in that technology is only a tool, and unless we think about what we're trying to accomplish and using the theory, and to Gary Filerman's point, in part, evidence and meeting the needs of multiple stakeholders, chasing the technology is the wrong way. We should determine all that other stuff first. The theory, what we're trying to deliver, how we're meeting our stakeholder needs, and then choose the platform that can help us best do that. Now, admittedly, some platforms might be better than others, but another one of my favorite little books, which is an airplane read, when we can all get back on airplanes, is Edgeware, and it's a book about complex adaptive systems. And the gist of Edgeware is when you have an innovation, think about the core aspects that you can't mess with, because you're going to trash the innovation if you do, and everything else you can mess around the edges. So, Tom, one answer to your question that I think about is, once you know what you're doing and whose needs you're trying to meet, is figure out those key things and pick a platform that delivers those key things, and then the rest is all window dressing, if you will, and pick something that works for you. I hope that's helpful. It's a oversimplistic answer to a complicated question, but I hope it's at least a start.
I think it's a good one. Thank you, David. Craig, go ahead.
Yeah, well, I was just going to say that we had to transition at the undergrad program, and many undergrad programs across the world changed to almost an exclusive online educational process. And what we learned in that process was the technology was just the enabler. What we really need to do is retool the educational design and the educational effectiveness of the teachers there. So because they plunked their same lecture that they did in a same period of time in an online setting and couldn't finish because the students were asking questions in the chat and they were pausing to answer. It was way more interactive, and they had to rethink the whole structure of that. People are now having breakout rooms and they're doing polls, in lecturing. So the whole educational environment was started to think. It was an opportunity to explore how to make online learning maybe way more interactive than often face-to-face is, which is just lecturing in small rooms as opposed to workshops. So I do agree with that. I mean, we have to, so we've spent a lot of time, I spent a lot of time around how to tutor and help people figure out how to engage in interactive conversation when eight students are in different rooms, different even cities. So a lot of interesting ideas about the technology is just the medium. It's not the end goal. We have to be more creative in the educational process.
I agree. I think we all agree, and I think that was the gist of Helena's presentation as well. Technology in support of good education and as an enabler, as an innovator in a way for the interactive engagement of the learners, and spaced learning, quite an opportunity again with technology support. So unfortunately, we don't have we over time already, and we could talk about this for a very long time. I want to thank all of you for your time, thoughtful remarks in preparing for this. I want to thank all of our participants for your thoughtful remarks and questions, and for spending time with us. I'd like to again point you to the additional resources and webinars as part of this journal club that may address some of these questions even a little bit deeper. And I would like to remind everybody that SACME conference, virtual conference, is happening in February. If you haven't signed up yet, please do so. There will be a lot of interesting programming that our programming committee put together, both from internal and external to our field experts. Very timely topics, a lot of topics from the practice, from the ground, from abstracts that many of your colleagues have submitted. And so an opportunity to engage in different ways. It's a virtual conference, and I think even the registration fees are very reasonable and adjusted to the times we live in. So thank you very much all for joining us. I wish you all very good holidays, safe times, and a better year ahead. And with this, just to remind you that the session was recorded, and you will all get a link to the recording. And I invite you to reach out to us with your thoughts, maybe complete the survey that we have put out for you, and that's how we will all engage as a community. Thank you. Stay well.